His airway is patent, you see no airway obstructions, and your partner is holding manual cervical spine. His breathing is shallow with diminished lung sounds, 28 breaths a minute, unable to take a deep breath due to upper back pain. C skin is pink, cool, and dry. Pulse is 138, SpO2 is 94, and Title's 35. He is conscious, confused to the fall, GCS of 14, and his pupils are 3 millimeters and equal bilaterally. Temp is cool, 42 degrees. Patient's temp is 98.4. So, what are we thinking about right away? Okay, back, neck injury, so we got that manual C-spine taken. Shallow diminished breath sounds, and unable to take that deep breath, right? Because of back pain. And so now we got that problem, right? Is he's self-splinting and not breathing deep because it hurts. So that's going to limit how much oxygen we take in. How much oxygen we take in is going to get limited, and our perfusion is going to get limited, right? He's a little confused, so maybe he hit his head. Right? And if we're thinking shock at all, I'm worried about that temperature of 42 degrees outside, right? That would be like going out right now. It's cold. I know it said it was 49 today, but it was a darn cold 49. Right? So what do I want to do? Keep them warm. Get them in the ambulance as soon as we can, right? Okay. Ultimately, we talk about the platinum 10, right? I think we talked about that 2 weeks ago when I was here, right? What is the platinum 10?
Platinum what?
Platinum 10.
Like your 10-minute.
That's our 10-minute goal for being on scene for a trauma patient, right? And the quicker we can get them where they need, the better off they are, right? So, can we get him in the back of the ambulance and do the rest of our stuff there? Yeah, it's probably the best place to do it, right?
When patients like this, are you okay to just bring the cot right up next to him and assist him or are we gonna manually move him from
You're gonna board him, aren't you, with a back injury?
Are we
So,
gonna board him?
if he's got, so remember, there's only a few reasons that we're gonna use to not board him, right? Otherwise, we're gonna board him. We're still boarding, but we're looking at those things, right? If he's got pain, okay, which he does in the back, right? And so right there, we go to backboard, right? If there was no pain, then we move to our next question, which is, what's his mental status? Is he a good historian? He's confused. No, right? So he gets backboarded. Anytime we can answer no to those questions, or yes to those
Are we
questions.
gonna see collar since the pain is mostly in the back?
Yep,
Okay.
because we don't know, right? He's kind of confused.
Well, I never know anymore.
I know.
Like it was yes,
So-
now it's maybe.
Maybe.
You would trust him that it's back pain and not like a rib fracture? I mean, like, does he know?
He doesn't, right? But his pain is back there. And we do have ribs back there, right?
Right?
But we don't have the luxury of x-ray or, x-ray glasses or anything like that, so protect, right?
You would
Just
have him and-
Yep. For this patient, is secondary survey performed in the field or during transport? During during transport, right? Okay, and then in that secondary survey, we'll get his vital signs, his sample history, that focused exam on his pain, right?
So, it's more like when we went through our EMT, when we talked about backboarding, we would always roll them, then do like our back exam, then put them back. Same thing?
Yeah,
Okay.
nope,
Well, I think it's always big too, how you find them. Is he sitting on the ground in a very protected, cause then when you go to try and move them on the backboard, sometimes they
Yeah.
wanna stay how they were.
they're
because
self-splinting, right?
Yeah.
And so if you have somebody that's self-splinting like that, do we want to force them to lay flat?
No.
So what do we do with them?
Transport.
Set the cot in their position of comfort.
Yeah.
Okay, or use your vacuum mattress, right? Because you can conform that to how they're sitting. And you just snug them in, and then you have something to help you lift them and move them. And they're still fairly secure.
So in lieu of the backboard, the vacuum mattress is the only other.
Sure.
Okay, you're not gonna put him on the regular cot in a position of.
Maybe, depending on how he's sitting, but I usually still want to, protect him a little bit. Then when we do that secondary survey, we're looking at their head, their neck, their chest, their abdomen, and their extremities, right? With this guy, because he's a little confused, would you maybe do a complete head to toe exam on him? Or would you do your focus just based on what he is complaining of?
No, you should do it all, because it
I would
would be.
start with the focus.
I would start with that focus, right? And then I would do a head to toe. What kind of clues can be heard during the second survey? Any breathing sounds, right? Stridor, wheezing, those are things that we can hear during that secondary assessment. Alright. What could be heard that would indicate an injury to the neck?
Gurgling.
Okay, air leaking, subcutaneous emphysema, or
Gurgling.
stridor, right? We get swelling in there, right? If I fall and hit my neck, is that gonna swell?
Yeah.
And if it swells, what's gonna happen to my airway?
Close.
It's gonna get closed, right? And if my airway starts to get closed, when I start breathing, I'm going to I have that stridor from trying to get that air past the swelling.
Could that have happened to the motorcycle guy too, or not so much?
Sure, with a bleeding from the neck like that? Yep. Could the patient's lung sounds lead you to hidden injuries?
Yeah.
So if I listen to this patient's lung sounds, and I hear really good lung sounds on the right side, but I don't hear lung sounds on the left, does that tell you something?
Yeah, probably got a broken rib injury there,
Okay,
punctured lung.
okay, so I probably have a lung that's got a pneumothorax, right, the pressure. Is there anything that you guys can do for that?
Bulky dressing.
Bulky dressing and rapid transport, right? All right, when you're feeling for injuries on the head, what are your hands telling you? I'm feeling it.
Soft spots.
Okay, soft spots,
Crepitus.
crepitus,
Is there blood on your gloves?
bleeding, swelling.
Is
Just by palpating, and a lot of times I find myself myself doing it, and I probably freak out my patients, right? But I'll close my eyes when I palpate. Because I can just picture, I feel better. It's kind of like when when a blind person, the rest of their senses get more heightened.
If it's a female, you're gonna look creepy.
You won't see their reaction, you don't care.
Yeah, my eyes are closed, right? But I do, I can imagine things more, I feel it better if I close my eyes when I do it.
I don't know that I don't close my eyes, but now that you say that, I do like look
Look away.
away. Yeah, I'm like,
That's worse.
Petting her, stop petting her. No petting in the ambulance.
unless you
Unless
bring
your
the
eyes
service
are
dog with
closed.
us.
So yeah, when you assess or feel a patient's neck, right? What are you feeling for? Crepitus,
Jugular distension.
jugular distension, subcutaneous emphysema, tenderness, right? We're feeling for all those things. How important is it to feel the patient's chest expand during the secondary survey?
I would say pretty important.
Pretty important, right? Put your hands on that chest, feel the excursion, right? Sometimes you'll feel one side go up and the other side not go up. And so a lot of times it's important to feel that and know the process.
So then close your eyes.
Beautiful eye closing.
I'm not gonna do that on a female
No, but
Feel
I'm
their
wondering, weren't we always taught to pay attention to your patient, like to look for signs of wincing in pain, or, if you hit something and they react to
and
it?
I feel that.
Um,
I do.
No, I'm not.
No.
If I hit something that's tender, I feel them wince or react.
Okay. Because I think how lucky it is for you to be able to have these calls every single day, where we maybe have one or two real traumas. I can't remember our last real MVA trauma or something like that. So for us, it would be a whole we're starting over.
Right. And that's why we do
So if
this.
this thing's gonna ring tonight, I want it to do it while Wayne is here.
So, but,
Give me a motorcycle accident right now.
Jesus, Janelle.
wow! Look at the time.
Notices, these are not wood tables.
I don't care, I want Wayne's here. What'd you say?
Because we don't
That's
do it
because
every day
Red
here,
probably isn't.
because we don't do it every day here, that's why we do this. So that we refresh ourselves. Right? I mean, I still go on scenes and, get the butterfly stuff
You
going.
never look at an EMT and go, what do I do? What would you do?
Yeah, but that's why we do it, that's why we talk about it. That's why next week when I come, we're actually gonna do stuff, right? And so, make you feel as comfortable as we can.
Yep.
So what injuries can be hidden in the abdomen?
Bleeding.
Bleeding. Right? There's so many things that can be hidden in the abdomen, right? What are some signs that we can see that tells us that we may have bleeding in our abdomen? Distension, rigidity, discoloration. And I'm really thinking about discoloration in two places. The first place is right around the umbilicus, all right? And if I have discoloration around the umbilicus, that is called Cullen sign, okay? And the other place that I'm gonna look for it is here in the flank, on the side. And if I see bruising or redness here, that tells me I've got bleeding as well, and that's called Grey Turner sign. So, if I see those signs and symptoms, I know I have some bleeding going on in the abdomen, okay? And maybe it's not just bleeding, maybe, remember, our colon, our intestine is hollow, right? And any blunt trauma to that can make that hollow organ perforate. And so it may not just be blood that's in there, it may be gastric contents. How do I know if they've got gastric contents in there? You really don't smell it, but they have the worst pain, peritonitis. And it's a really diffuse pain. It's not like, oh, it hurts right here. It hurts all over here. And that's that bile and those gastric contents hitting the peritoneum and irritating it. And it doesn't like it.
Does GI bleed smell?
Yes.
What's it smell like?
So it depends on what's end it's coming out.
Oh, so like,
Okay, so if it's a lower GI bleed and it's coming out as black tarry stool, that is, once you smell that once, it's a smell you will never forget. Okay, if it's upper, higher in the GI, then we see the coffee ground emesis, and that also has a stench to it, but not nearly as bad as the black tarry stool. So we can have a lot of things hidden in the abdomen, right? Why should we palpate the pelvis? With caution.
You don't wanna make it worse.
Because we don't, if it's an unstable pelvis, do we want to go, Frook?
Nope.
Sister?
Does that hurt? Right? Okay. We can cause a lot more damage. So when we check the pelvis, we check it gently, right? We're not really doing a lot of force, but we're seeing if there is stability or no stability. Right? What kind of injuries would we find while feeling the extremities of the patient?
Fracture, breaks.
Deformities, right? Which could be fractures,
Dislocation.
dislocations, swelling,
Yeah.
decap DTLS. Way to go!
Had a good teacher. He's old though.
He's very old. So when and how frequently should you calculate your patient's GCS?
If something changes, like if I have an initial one and everything's good,
Every time I reassess, I'm gonna redo their GCS, right? Because they may change. So I do it initially, and then every time that I do a reassessment. And if they're stable, I'm gonna do that reassessment, how often? Every 15 minutes or so? And if they're not stable, I'm gonna do that reassessment every 5. And if they're really unstable, I may be doing it every 3. Right? Just so that I can see changes quickly. What can you tell from looking into someone's eyes?
Pain, fear,
Fear, pain,
a lot of things.
Could give you an indication of what's going on inside their head, if there's some kind of a head injury there.
okay, like
Pupils.
pupil
Pupils,
size.
yeah.
One blown and the other not, are they tracking, are they?
Mhm.
Yep.
Yeah, a lot.
So you can tell a lot from looking at somebody in the eyes.
The Native Americans don't
Brian,
like you to
what can you
look in
tell
their
by
eyes.
looking in her eyes?
A
If you're in trouble or not?
ask my mom about her blue-eyed devil that she is. She got called that from a carny one.
yes.
He broke the nylon straps off the board, he was so big out. He had his Dexter Mosley. He had Dexter tattooed across his chest and his last name was Mosley across his back. And he kept asking Eleanor DeSanko, he just wanted to go to, not the shelter, what did he call it? Mission. He just wanted to go to mission. And don't beat me, Master, please don't beat me, he was obviously an African-American, and I was the blue-eyed devil, so I kept my distance.
So you kept your eyes closed?
I kept my eyes closed. I was watching him the whole time.
And the exit.
How often should we check CMS? Okay, initially, anytime you move the patient, and
Squinting and whenever you reassess.
and then when you reassess, right? Do we do manual blood pressures, or do we do our machine right away?
I do a manual if I get something really, if my machine gives me something weird, I will grab a manual cuff right away.
Yeah, I've
Or
been
if
doing
you
more
error, I'll
manuals
right away.
lately.
What's that?
If you get an error, I'll
Yeah.
right away on it.
But I'll admit, it's hard to hear in the.
It is hard to hear in the ambulance.
I usually just do a palpation,
No?
stethoscope.
So we get their blood pressure, pulse rate, quality, ventilatory rate, breath sounds, O2 saturations. You guys aren't gonna do end tidal, right?
Should we?
Harvey does not do it.
End tidal can be good, but it will give you so much information that you're not gonna be able to do anything about it. So am I really concerned about you doing an end tidal? Not really.
I think you would have told us 10 years ago what you would have thought.
Yeah. Alright. And then BGL, right? Get their BGL.
Do you know why? We have our little BP machine that we've always had, and that one you'll get an error a lot easier, but you don't often get an error when you use the 12 lead. Why does the same amount of movement in that rig not affect that 12 lead like it is that little machine?
It's how that 12 lead is calibrated and the quality of the
It's a lot heavier.
instrumentation.
Right, but I mean, it's the same movement in the rig. I mean,
But the little plastic, our little portable one is not.
because there's times that one won't work, and if I switch them over right away to the 12 lead, you can get one off of there right away,
Yeah.
so.
Yeah, it's basically quality of what the insides. Get your sample, right, your signs and symptoms, allergies, medications, you know. And a lot of people, when we're talking about trauma, they skip this. Why would you skip this? This is important, right? Especially the medication part. When we talked about medications that our patient could be on, that could affect how they respond to shock, right? So it's important to ask those questions. So this is what our patient looks like on secondary survey. Heart rate's 138. SpO2 is 94%. Their end tidal's 35. Respiratory rate 28. Blood pressure 106/40. Temperature 98.7. Anything on there concern you?
Is this the guy that fell on the left?
On the left.
Same guy.
I know we've done, that was, seems like a long time ago
The heart
we got
rate.
dispatched, right?
The blood pressure.
The blood pressure.
The blood pressure,
The heart
okay?
rate.
That's how I right away.
So, pulse is up high, right? Respiratory rate is up high. Blood pressure is lowish, normal. So he is
Yeah.
What do you mean lowish normal?
Lowish?
That's low.
40 is low. Yeah.
okay.
Definitely something to watch.
So he is,
Shocky.
he's shocky, right? He is shocky.
Which shock would he be?
I
Neurogenic.
would say neurogenic. I would start there because of the back pain.
Okay.
Maybe cardiogenic.
For EMTs though, that can't do anything with fluids,
Right?
our treatment is gonna be the same exact on every
Diesel.
single shock person. Diesel.
Load and go.
Get him diesel.
Yeah.
Diesel.
Get him going, right?
It was just, it's like, you guys have to say,
Secondary survey shows the patient has upper and lower back pain, and unstable pelvis was found, which could be causing his lower back pain. And the patient's neurologic exam is within normal limits. You want to change your shock now?
Let me read again. Upper and lower back pain, unstable pelvis, oh yeah, I would maybe go more hypovolemic if with.
Okay, because we talked, right? Unstable pelvis, fractured pelvis, we can lose a lot of blood. Right? And his neurologic exam was normal. So you completed your secondary survey en route, transported to a level 2 trauma center. Patient was found to have a minimally displaced pelvic fracture, a concussion, and a contusion to his upper back. Spent 4 days in the hospital, a week in rehab before going home for continued recovery. Things we could have done. Pelvic binder, right? You notice that's the first thing they talk about, is that pelvic binder, to make that more stable, right? Spinal motion restriction device, your backboard, your seat collar. Providing oxygen, why? Treatment for shock, right? Okay. Analgesia for pain management, you guys aren't gonna do that, right? And cover them with a blanket, keep them warm, treat that shock.
It's like 100% safe. We're doing good, 100% safe.
You're right, our survival rate is very high.
Yeah.
So, that's good.
Okay, we'll talk about traumatic brain injuries, right? So, traumatic brain injury. When you think about traumatic brain injury, what's one of the first things you think about?
Service dogs. Service dogs.
Service dogs?
Oh.
Okay,
Someone hitting that.
somebody hitting their head? So is a concussion a traumatic brain injury?
It's a type of traumatic, it can cause,
It can be, it's
yeah.
a form of traumatic brain injury,
Mm-hmm.
okay? What?
She's
Maybe
on
the
over here.
CTE.
It could lead to CTE.
Yeah.
What is CTE?
Craniotic, blah, blah, blah. I don't know.
Chronic traumatic encephalopathy.
She's getting a little low on sugar, so she's eating a Reese's.
So, yeah, a concussion is a very mild form of traumatic brain injury. Remember, concussions, we've got certain levels. You know, the very basic, get your bell rung, you know, get your head coming out of the back of the ambulance on the door,
Done
rings your
that.
bell. Everybody's done that, haven't they?
Yes.
Oh, yeah.
It's like a rite of passage.
I hit the mirror, the driver's mirror kind of rubbed Hold it back.
Right?
It's
And so those are minor types of traumatic brain injuries. Over 10 million people have TBIs every year. That's a lot. In the United States, about 2.8 million occur yearly. That's one person getting a TBI every 21 seconds. TBI is the most frequent cause of death and disability among children in the United States. That's scary. Common causes. What are some common causes of traumatic brain injury? Sports, car accidents, falls, violence, Those are all common causes of traumatic brain injury. Alright, you're dispatched to a report of a male who was riding at a skate park, fell and hit his head. Seen as safe, 122-year-old patient. A, he's too old to be riding a skateboard. B, he wasn't wearing a helmet.
And he was riding down the rail.
Yeah.
Trying to impress a girl, probably.
Friend tells you they were trying to see who could ride the longest down the rail when the patient fell. Struck his hand first, then his head on the concrete. And he was not wearing a helmet.
See?
And kind of from what I see, I don't see any protective equipment. So I don't see any elbow pads, wrist pads.
His head's not even on the ground yet.
It's an action shot. So.
Images everything.
He's trying to, yeah. He's trying to.
I'm just saying.
They were trying to record a video, so that's why.
So,
The latest TikTok.
what are the concerning physics of the trauma for this patient? Okay, speed,
Impact.
impact on concrete,
Yeah. How high are
Height.
you?
okay? So what injuries may we see in this patient?
Any and all.
Any, yeah.
Okay, put his arm and hand out.
Yeah.
Broken, dislocated arm, hand, wrist.
Hand, wrist,
Shoulder.
fracture,
The elbow could be-
elbow,
shoulder.
right, shoulder,
Yeah, his fingers.
facial trauma,
Head injury.
head injury,
Concussion.
concussion, other brain, traumatic brain injuries. Alright, you're seen as safe. Patient is lying prone. He's got a hematoma and abrasion to the right side of his head. Lying prone, anything that you're concerned about right away? Airway. Right? We already looked when we came up, didn't see any exsanguating bleeding, so now we're worried about that airway. If he's prone, right, we gotta worry about how he's laying, right, and is his airway open? He's got oozing dark blood from the right side of the head, an open fracture to the distal right radius ulna, no active exsanguation. Airways patent, no airway obstruction, your partner is performing manual inline stabilization. He's breathing at 20 times a minute, lungs are clear bilaterally, skin is pale, warm, and dry, pulse is 100, SpO2 is 92%, patient's conscious, confused, GCS of 13, pupils are 3 millimeter and equal bilaterally, but they sluggish when you shine the light in. It is 78 degrees outside, his skin temp is normal, right forearm is deformed with a bleeding open fracture. Any concerns there? Shocking maybe? Okay, is there any need for hemorrhage control?
No, he's not actively
No,
bleeding anymore.
he's got oozing dark blood out of the side of the head, but he's also got an open fracture there, so are you going to put pressure on it? Why? Because we'll push that bone down into the brain, right? Okay, so if anything on that one, we would lay a gauze up over it and wrap it, right, dress it. Okay. Is air management indicated? At this point, probably not. He's breathing adequately, his airway's open. Spinal motion restriction indicated? Mechanism of injury, and he is confused, right? So then we're gonna take care of that motion restriction. And could he have a traumatic brain injury? Absolutely. Right? So why is the brain unique in terms of a traumatic pathophysiology? What makes the brain unique?
It crosses hemispheres.
think about it, our brain is in our skull, right? Our cranium. And that cranium's job is to protect the brain, right? But because that cranium is solid, right? If we start to get swelling inside the brain, what happens?
It goes down your axis.
It has nowhere to
There's nowhere to
go,
go. It goes
right?
down your spinal
It has no extra room. Our brain is made with just a little bit of meninges and cerebral spinal fluid around the outside to cushion it. But other than that, it's tight. And so when we get swelling, it's going to start pushing up against the cranium, and it's not going to be able to go anywhere, right? So what happens when it can't go anywhere?
Then it goes down into
It goes down, right? The only opening that we have, where the brainstem comes down and the spinal cord comes up. What's that called?
I used to know.
The foramen magnum. Right? That's where that means. And so what happens is then everything starts to push down, and the brainstem starts to come through that foramen magnum. Okay. Now, when that brainstem starts to come through, what's controlled in the brainstem?
Yeah,
Hmm?
everything.
Respiratory rate, heart rate.
Respiratory and heart, right? So if that starts to come through the foramen magnum, what's the first thing that's going to stop?
Adequate
Breathing.
Our breathing, our adequate breathing, right? So that's what makes our brain unique as far as trauma, right? The brain needs a constant flow of blood, right? The brain uses 40% of the body's blood supply and oxygen and glucose. That's a lot, right? If our patient's blood pressure decreases, what's going to happen to the perfusion of the brain? It will also decrease, right? Because we don't have enough pressure pushing that supply up to the brain. Alright? That can cause our blood vessels in the brain to dilate, causes more blood into the confined space of the skull, and leads to increased intracranial pressure. Again, we talked earlier, right, about brain swelling and trauma and what we really need to do as far as breathing for our patient, right? Give them that little bit of extra ventilation, right? Give them a little bit of hyperventilation to help with that end tidal. How would you manage this patient's initial oxygen needs? He was on 92%, right? We want to keep our patients where? 94 and above. So how would we initially give him oxygen? Nasal cannula?
Depends on where that fracture is and what's comfortable.
Okay.
We might do a mask just to not be messing with his nose if there was.
Trauma there. Okay. Okay. Should we spinal immobilize him? We said that earlier, we would, right? Alright, primary brain injuries include concussions, brain contusions, intracranial hemorrhage, whether it's epidural, subdural, subarachnoid, or intracerebral, cerebral laceration, and then diffuse axonal injury. When we look at our brain, there is this area right here called the circle of Willis. You can kind of see this dark spot here. There should be the same dark spot on this side, but we have so much pressure pushing down on it right now that that's kind of disappeared. But this is our main blood supply in the brain, is at that circle of Willis. So if our pressure is pushing down where I can't see that left side of it, is my patient getting enough blood flow to the brain? Okay, they're not. And so, again, is there really a lot we're gonna do in the field for this patient? Except for maybe giving them a little extra ventilation. He needs to be where?
Trauma
He
center.
needs to be in surgery, okay? He needs to have a hole drilled into his head and release the pressure so that he can normalize again, right? You guys know what diffuse axonal injury is? So the axons in our body, science teacher Kelsey, what do those axons do?
They send the neurological messages.
Okay, they send those neurological messages to our nerves throughout the body, right? So, like if I touch a hot stove, my fingers send a signal to my brain saying,
Move your hand, dummy.
hey, it's hot, move your hand. My brain sends a signal back to the hand, tells it to move. All that happens within milliseconds, right? Okay? All that happens through those axons. And those axons are actually kind of longer, and they kind of look tubular, right? Sometimes if we get hit in the head, right, just by going boom and shaking my head, or if you had a really good rock concert, I used to have long hair, I could do that. Okay? You can cause those axons to actually pull apart. And by pulling them, when they pull apart, can they send signals anymore, send those messages? Okay? And so that's what that diffuse axonal injury is when those axons actually get pulled apart, and now we have no communication between the brain and certain parts of the body. And that may be why a patient doesn't feel you touching them, right? Because that axonal injury is not allowing that signal to go through. Okay, skull fractures is just that, right? We have a fracture to the skull. Sometimes we can have an open skull fracture, right? Where it's open, you can see all the way down into the brain, you have brain tissue coming out. That's pretty nasty. You can have depressed skull fractures, right? Where you've got a concave in the skull. It's all still there, but it's kind of in pieces, right? And that's depressed skull fracture. And sometimes you can just have a closed skull fracture. Just a little linear split in the skull like you get in bones, right? The problem with any of these skull fractures is it can increase risks, and it can increase the risk of infection to the brain. Our brain doesn't like that stuff, right? Our brain does not like anything that's not supposed to be in there. And that's how it ends up having problems. Alright. Other brain injuries we have not discussed. Cerebral concussion. Right? Get your bell rolled. A lot of times with a concussion, you'll get post-traumatic amnesia. You don't remember what happened at the time of the injury or shortly after. You ever pick up a patient from that hit their head in an accident or a sporting event, and they ask you over and over and over again, what happened? Was I in an accident? What happened? And you can tell them over and over and over again what happened, and they're not going to remember, right? So sometimes I just give up, quit answering after about the 50th time.
Close your eyes.
And close your eyes. Take a nap, right? So what are the symptoms of a concussion? A vacant stare. delayed verbal or motor responses, confusion, inability to focus their attention, disorientation, slurred, incoherent speech, lack of coordination, emotions that are inappropriate for circumstances. Ever have somebody just giggle and giggle and giggle and something terrible happened? Memory deficits, inability to memorize and recall. All different things that we could see. All right. Hematomas, bleeding in that brain, epidural, subdural, intercerebral. Epidural happens kind of on the outside of that dura mater. Generally, those we see symptoms in right away. Okay. Subdural, that may be the patient that you go to a motor vehicle accident and they feel great, they're fine, they don't want to go to the hospital, they sign a refusal form, and 2 days later you're called to their house and they're unresponsive. Because it takes that long for that bleed to build up to where they'll start having symptoms. And then intercerebral, we'll see that bleeds in that circle of Willis, and pretty much the moment that bleed starts happening, they have symptoms. And that intercerebral hemorrhaging or hematomas, the only fix for it is they actually cut a plate off of the skull, pull it off, go in, and they wrap that vessel with a coil. That's the only way to stop the bleed. And that's just what we talked about. And there's that diffuse axonal injury. All right, so what is the condition of our patient? What kind of brain injury might the patient have? Can have subdural hematoma. Could just have a concussion, right? Is he stable or unstable? Unstable with that altered mental status, right? Okay. You apply spinal motion restriction, give him supplemental oxygen. You guys over here might start an IV. You start your secondary survey, you know the patient's no longer talking to you. How would you reassess that? So now my thought process goes not a subdural hematoma, but well, maybe an intercerebral or an epidural, right? Because those are the ones we're going to see those symptoms in right away. All right, patient has a laceration in the right temporal region with a depression of the skull. Pupils, the left is 3 millimeters, the right is 5 millimeters and non-reactive. That tells us right away that we've got a brain injury, and it tells us that we're starting to see that increased intracranial pressure. No step off or pain noticed in cervical spine. Chest, lungs are clear bilaterally, no noted injury. Abdomen is soft, non-tender, no masses. Pelvis is intact. Extremities, neurologic, patient has open fracture to the distal right radius and ulna. Heart rate's 56. SpO2 90%. Blood pressure 168 over 112. Temp is 101. What did we talk about, those things, that triad? Okay, does he have it? Increased blood pressure, decreased pulse, right? Respiratory rate's gonna change, not be normal. Definitely has increased intracranial pressure.
So this would be neurologic shock then, or no?
Yes, because it's an insult to the brain,
Okay.
right? What do unequal pupils indicate in this patient? Intracranial pressure, brain injury. So what's most likely happening in that brain cavity?
Swelling.
What we talked about earlier, right? All that pressure and it's starting to push the brainstem through the foramen magnum. And we call that a herniating brainstem. Okay. So when we start seeing that go through, we start to see the change in the respirations, the change in the breathing. The farther that brainstem comes through the foramen magnum, we start to see that posturing, right? Where they curl in or everything extends out, right? Decorticate and decerabit posturing. How does mass affect the present in a brain injured patient? So if they had a mass in their brain, is that going to affect my brain injured patient? Because it's going to make less room in there, right? We have less room even, more. So then we see that corticate decerabit posturing. Asymmetric pupils, dilated non-reactive pupils, decreased neurologic status. So here's that ventilatory rate that we're talking about, right? Increasing their respiratory rate up to 20 breaths a minute, right? Instead of 10 to 12, we're going to give them 20 breaths a minute to help blow off that carbon dioxide. From that injury to the brain, we can get secondary injuries. Hypotension, hypoxia, cerebral edema, infection, seizures. Those are all secondary injuries to that first injury to the brain. How do we prevent a secondary brain injury? Rapid transport, right? Recognizing what's going on, giving them that hyperventilation. Those are all things that we're going to do to help prevent that secondary injury. All right, bleeding is controlled, airways maintained with nasal airway and bag valve mask. Breathing is maintained by mildly hyperventilating the patient. Blood pressure is 168/90. Patient's color improves, his pulse is 56, strong and regular. Serial neurologic exams are completed. He has decerabit posturing. En route to the hospital, you complete your secondary survey, transport him to a level 1 trauma center, CT scan, and OR was mobilized for evacuation of a large epidural hematoma. After surgery, patient was admitted to trauma ICU with continuing care. So, what were the critical things we needed to do? We needed to recognize that brain injury, right? Recognize the signs of, increased blood pressure, decreased pulse, manage that, and reassessing your interventions. We need a break. Stretch.